Spinal cord injuries. There are four mechanisms of injury. You can have a hyperflexion, hyperextension, compression. That would be like if you fell off a ladder and landed on your butt, or a penetrating, which would be some sort of a traumatic injury like a gunshot or a stabbing or impalement or something like that. Your anterior cord, because that is where your motor spinal nerves exit. If you have damage to just your anterior cord, you're going to have a loss of motor function. If you lose or damage your posterior cord, then you're going to have a decrease in sensation. So some patients may have decreased motion but maintain sensation, or vice versa. Or if they have a complete transection of the cord, then they will lose both motor and sensory function. A Brown-Séquard injury is where one side of the cord, both front and back, so it's ipsilateral, um, causing damage to motor and sensory function on just one side of the body. Or you can have central cord damage, sometimes which happens with compression fractures or diving into a shallow pool and hitting your head, that sort of thing. You can lose motor function in the upper extremities, but not lose as much function in the lower extremities. So let's look at an unfolding case study. We have Zach Wright, age 20, pulled from a local pond, resuscitated, dove into shallow water, and he has a C-spine injury. The paramedic field report is that there's no movement or sensation below the clavicles, so put a pin in that. GCS, Glasgow Coma Scale, is 10. He's intubated at 100% oxygen via ambu bag. He's alert, anxious, and grimacing with pain. Perla, pupils equal and reactive to light and accommodation. Skin below the injury is cool to the touch. Blood pressure is 90/60, pulse is 45, respiratory rate's 27 via the ambu bag, and the IV is at 100 an hour, lactated ringers. So our assessments, we're going to look, and this is something very common in emergency room situations, what we call ABCDE, airway, breathing, circulation, disability, such as a neuro problem, and E for exposure. So think about, and I have listed a lot of different ways that we are going to assess and address life-threatening issues related to airway, breathing, and circulation. With disability, we do a quick neurological assessment if we suspect that there is a possibility of neurologic damage. And then exposure, where we cut off the clothes and expose everything so that we can determine if there are any other potentially life-threatening injuries in that patient. Now let's look at the vital signs for this patient. Blood pressure 90/60, pulse is 45, and in that paramedic field report, it does say that the skin below the injury is cool to the touch. This indicates something called spinal shock. And this is where the patient has flaccid paralysis below the level of the injury, loss of reflex activity below the level of the injury, and hypotension and bradycardia, because your sympathetic nerve impulses, your autonomic nervous system, is being interrupted by this injury. So we have a decreased ability to maintain body temperature below the level of injury. That's why the skin is cool to the touch. There is increased sweating sometimes, or the inability to sweat, depending on what type of damage. There is no peristalsis or bladder function. There is postural hypotension because the body is not able to vasoconstrict. Remember, we've interrupted sympathetic nerve impulses, and there are no reflexes. Now, this can take weeks or months to resolve, partially resolve in some patients, where they may begin to start having a return of reflexes. Our ongoing assessments are going to be things like our CBC, our urinalysis, our chem studies, clotting, chest x-rays, C-spine X-rays, MRIs, CAT scans, all to determine the extent of possible internal injuries and the extent of the damage to the spinal column and the spinal cord. In terms of our pharmacology, we're going to give methylprednisolone, solumedrol, which is going to help to reduce spinal cord edema and decrease the level of nerve dysfunction. So this will be very, very helpful in getting a really good picture of what the extent of the damage is. When we have injury to any part of our body, there's always swelling. And with a spinal cord injury, we could have swelling above as well as at or below the injury, actual injury. With methylprednisolone given within the first 6 to 8 hours after the injury, that can decrease swelling significantly, possibly prevent further damage to nerves that are above the level of the injury, and again, give us a good indication of what the extent of the problem might be. Dextran, one of those plasma expanders that we talked about when we discussed shock, that is going to help to increase blood flow to the spinal cord and maybe do some repair or reduce the damage. Atropine, because we are bradycardic. Dopamine, the vasopressor, so that we can increase the blood pressure. Pain meds, anti-anxiety meds, all of that help to reduce energy consumption and help for healing. Dantrolene and baclofen are antispasmodic medications. We may also see these given to patients who have multiple sclerosis to reduce muscle tremors. And then any kind of PPI or histamine blocker to prevent stress ulcers. Now, here are some ways that we can treat patients who have had cervical spine injuries. This is cervical skull traction, where we put this into the skull and then hang a weight off of it, and that keeps the vertebrae separated and immobile so that we don't cause any further damage. We can see a Stryker bed, not used as much anymore, but you still may possibly see it. And this is when it's too dangerous to log roll a patient with a spinal cord injury. They lay face down on this, and then we lower that mattress down on top of them when we want to flip them over. And in this case, it's kind of head over heels, but there are some Stryker beds that go side to side. We can't really log roll them and prevent pressure ulcers any other way than to use this particular device. And then some patients may have a halo brace. They may have them for several months after a cervical injury, or it could be a lifelong situation. So these are bolted into the skull, and then this keeps the head immobilized, and prevents the patient from doing any further damage, particularly if their neck muscles are so weak that they're not able to hold their head upright. So after 2 weeks in the ICU, he is transferred to the rehab floor, and he has a trach with spontaneous diaphragmatic breathing. He has continuous tube feedings at 60 an hour. He has movement in the upper arms and feeling to the nipple line. So let's go back to what we talked about with the paramedic field report, where he only had sensation above the clavicles. Now it's improved to the point that he has sensation to the nipple line. So that means that his upper arms and shoulders are going to be able to move, and this is going to make some rehab and maybe some return to some functioning a lot easier. He has a halo device. So think of the kinds of things that you would be doing if somebody has an apparatus like I just showed you bolted into their skull. We're going to be doing pin care. We need to prevent infection. The blood pressure drops when the head of the bed is raised. So this is a severe orthostatic problem that can resolve within a couple of weeks, maybe longer, maybe long-term instability. And that's why you see some patients in wheelchairs that are quadriplegics or paraplegics. Some of them are able to sit upright. Others are in a constant reclining position because they can't tolerate sitting upright without losing their blood pressure. So think about the orders that you would anticipate for this particular patient. A week later, we're having physical therapy, occupational therapy twice a day. We have a bowel program every other day. These patients, again, they have no control over their bowels, so they don't have any sensation of when they have to move their bowels. So they're usually on a very complicated regimen of stool softeners, Miralax, suppositories, Fleet's enemas, and that sort of thing. And even possibly manual disimpaction. He's tolerating his head of the bed at 45 degrees, keeping a stable blood pressure. He's tolerating a soft diet. His pain is controlled, and he has a very positive affect. But now he's suddenly ringing the call bell. He's complaining of headache, nasal stuffiness. His skin is flushed. It's cool below the level of the injury with goosebumps. What is happening? This is something called autonomic dysreflexia. And this happens oftentimes with patients who have high thoracic level or higher spinal cord injuries. It can happen with some patients do not experience this. And what it is an exaggerated autonomic response, which can be caused by three major factors that we need to teach our patients to minimize and avoid. And then we have to discuss what type of treatment that we have to do for this. So one of the ways that this can be triggered is with an overdistended bladder. These patients don't have bladder sensation, so they have to have a Foley catheter or a suprapubic tube, or maybe they're on intermittent straight caths, and somehow their bladder becomes distended. So the first thing that you want to check in this situation is their bladder. If their tubing is kinked or their catheter needs to be irrigated, then do that and drain that urine out of that bladder. The next thing that could possibly happen would be an impacted rectum. So if the bladder is okay, then we're going to check the rectum and we're going to disimpact them if we have to. The other thing that can trigger this is tight clothing. And this is a neurologic emergency because in this exaggerated autonomic response, the patient's blood pressure goes sky high and we have to get it down. So even though he has orthostatic issues, and even because he has orthostatic issues, we want to sit the head of the bed up as high as possible because that will help to bring his blood pressure down in this particular scenario. And we have to instruct the patient on how to avoid these types of situations because it can be very, very serious. Okay, so let's talk about seizures now. So what is the difference between seizures and epilepsy? Seizures are when patients have abnormal electrical activity that's caused by some kind of an underlying problem. Could be a traumatic injury, could be a disease process, could be a high fever. Babies get febrile seizures. But when you just have a seizure, then if you correct that underlying problem, the patient will probably not have any more seizures. Versus epilepsy, which is a chronic condition of unprovoked seizures that are not specifically related to an underlying disease process. And it is a chronic situation that patients have. There are two types of seizures. There are partial and there are generalized. So your partial seizures, and these are described in box 46-1. Simple is where you are conscious throughout the seizure. Complex is where the patients lose consciousness. And then the complex seizure, partial seizures may also be referred to as psychomotor or temporal lobe seizures. And then we have generalized seizures, the things that we think of most when we think of somebody having a seizure. And the most common one that we think of is something called the tonic-clonic seizure. And this is where they have the tonic, which is the stiffening and the tightening of the muscles, and clonic, a rhythmic jerking of the muscles. And the patients lose consciousness. This is what used to be referred to as a grand mal seizure. So patients with tonic-clonic seizures, they will lose consciousness. They will often have be incontinent, And once the seizure is over, it may take a while for them to wake up. So they will be in what is called the post-ictal phase, POST-ICTAL, the post-ictal phase, for a while. And it may just take them a while to wake up and regain full consciousness. The tonic is where you just have increased muscle tone. The clonic is where you're just having relaxing and jerking of the motions of the muscles. Absent seizures are what used to be called petit mal seizures. And that's with a brief loss of consciousness where they're basically kind of staring off into space, kind of like what they used to punish kids for back in the day, staring out the window during class and not paying attention. And some of those kids may have been having absence seizures. Atonic is where they lose total control of their muscles and they just drop. And then myoclonic is very brief jerking and stiffening of the extremities. So it looks a little bit like the tonic-clonic, but does not have a loss of consciousness, but may be followed up with some post-ictal confusion. Now, status epilepticus is when we have repeated recurrent seizures over the course of more than 5 minutes or multiple seizures within a short period of time. And that is a medical emergency. We need to stop the seizures as quickly as possible. Some of the causes of status epilepticus could be the sudden withdrawal of anti-epileptic drugs, um, cerebral infections, alcohol withdrawal, head traumas, so any kind of metabolic disturbances. And these patients will just continue to have seizures until we treat them as quickly as we possibly can. So we need to make sure that they have an open airway. Well, we can't do anything about it while they are actively seizing. So we have to do the best that we can. We can't put in an airway, but we need to position them to open up their airway, administer oxygen. Hopefully, they will already have IV access so that we can administer anti-epileptic drugs. If they don't, there are some anti-epileptics that we can give rectally. We can give diazepam rectally, called Diastat. But we need to stop these seizures as quickly as possible. And usually we do that by giving them benzodiazepine medications like lorazepam and midazolam and diazepam. So our pharmacology, there's a chart on in 46-1, has a boatload of different anti-epileptic drugs. You're not expected to memorize all of them, but there are 3 very common anti-epileptic drugs that they like to ask you about on the NCLEX, primarily because number 1, they have therapeutic ranges that we need to attain with them. And they have a potential for toxicity if they go over that range. There are also some interesting and significant nursing implications that are associated with these. So we're going to talk about these more in class, but the information is on your expanded notes pages. And you do need to know the therapeutic ranges and the nursing implications for phenytoin, otherwise known as Dilantin, which we talk about a lot because it's been used for years and years and years, and you will have many patients that have been well regulated on phenytoin for many, many years. Carbamazepine and valproic acid are asked about a lot on NCLEX because they are also used in psychiatric disorders. So your duly diagnosed patients may be on these medications, and that's why they come up on a regular occurrence with the NCLEX. And finally, let's talk about seizure precautions. Um, Setting up the room to be safe for the patient who is presenting with a seizure disorder. We need to have oxygen and suctioning equipment in the room. We want to make sure that they have IV access. The side rails should be up at all times, and we should have padded side rails available. Or if they are not allowed in your facility, then you would have to have the bed in the lowest position possible. When the patient has a seizure, you want to document what they may have said or done prior to the seizure, because sometimes they will experience an aura, a precursor, and they will say something like, "What's that funny smell?" or "I've got double vision," or they may cry out. And then you want to document the time that the seizure started, anything that happens during the seizure, and then document the time that the seizure ends. While they are having the seizure, you just need to keep them safe and free from injury. If they're sitting in a chair, you may have to try to lower them onto the floor so they don't fall off the chair and injure themselves. And then move everything out of the way so that as their arms and legs are moving around, they don't injure themselves on that. Put them in a side-lying rescue position if possible. So if they vomit or they have excessive secretions, they don't aspirate. But don't try to put anything in their mouth. Don't try to restrain their limbs. Don't do anything to injure them or yourself during the course of the seizure. And then once they're awake, then you're going to clean them up. If they have been incontinent, you're going to do some vital signs, make them comfortable, and document anything that occurs after the seizure itself. Some long-term treatments that we can do for patients if they are not responding to medication and they're still continuing to have seizures. We can do an awake craniotomy, like you saw when we talked about the awake craniotomy video, where they can identify where the seizures are originating from and then destroy those brain cells if they are not in vital areas so that they don't keep firing those electrical impulses. They can also have something called a vagal nerve stimulator that is an implanted device that the patient can activate when they have an aura, and that can help to prevent a seizure. So it's always very, very important to document what the aura is so that the patient or the family member are now able to identify when they're having an aura. Or they can have surgery to actually remove the epileptic region of the brain if they are not responding to maybe the vagal stimulation or the awake craniotomy, and just kind of like an ablation you can almost do for that.